Hello, my name is Graham Titherley-Strong and I'm an orthopaedic surgeon at Addenbrooke's Hospital, which is part of the Cambridge University Hospitals Trust. And today I'm going to talk about the examination of the shoulder. The shoulder's large humeral head and relatively shallow glenoid socket make it the most mobile joint in the body, but potentially the most unstable. Fortunately, the shoulder rarely dislocates due to its surrounding ligaments, muscles and tendons, which are constantly working to keep it in joint. As a result, the vast majority of shoulder conditions are related to soft tissue pathology, instability or rotator cuff disease, rather than to osteoarthritis. Examination of the shoulder entails look, feel, move, comparing sides and special tests, which are for either joint instability or rotator cuff disease. The old adage for all orthopaedic examinations is look, feel, move, special tests. So the first thing to do is to look at the shoulder. So it's essential that you can really have the patient exposed to their waist. And obviously for women it's important for them to wear something like a vest top so you can see everything that's going on. So we want to look at the sternoclavicular joint. There often may be some asymmetry. The clavicle itself is subcutaneous and often patients may or may not have had a fracture and you can see an obvious malunion there. The AC joint varies from person to person, but you're really looking for symmetry. So if someone's had a previous AC joint injury, you can see that. If I get Sam to turn around posteriorly, just have a look at his back. What we're looking at symmetry once again of the scapula, so we can see the medial border and the inferior border of his scapula. If someone's had a long-standing rotator cuff tear, they may have some atrophy, so you may notice that there's a relative atrophy of the supraspinatus or the infraspinatus on these fossa. Sam's entirely normal, so we're not expecting to see anything like that. So having had a look at the patient, the next thing is palpation. Different people do things different ways, but this is the way that I do it. I always stand behind the patient and I palpate and ask them to tell me if there's any discomfort. And once again, we're always talking about symmetry. So I start at the sternoclavicular joint and ask if there's any discomfort there. Then I'll slowly come along the clavicle to see if there's any pain. I'll then start on to get to the AC joint and press deeply on there to see if there's any discomfort. You can then come around the acromion, pressing for any pain, and then along the spine of the scapula to see if there's any discomfort. There are a couple of bony landmarks that it's also important to identify. The Coracoid Process, you can see it's just really below the AC joint and there's a little bony prominence and you can push in. Just to check you've got the right position, there's another bony prominence just lateral to that. If you get the patient to internally and externally rotate your arm, my index finger is now on the lesser tuberosity. Just lateral to the lesser tuberosity is the bicipital groove, so that's where the long-headed biceps tendon runs. So by me just moving my finger slightly more laterally, I'm now pressing on Sam's long-headed biceps. If he had any long-headed biceps pathology, he'd notice that's uncomfortable. Slightly lateral to that is the greater tuberosity, and that's the insertion of supraspinatus, which is the most commonly affected rotator cuff muscle. So if someone's got a rotator cuff tendinitis, they may notice they've got some pain there. So palpation of the greater tuberosity is looking for some discomfort there. So Sam, I wonder if I could get you just to lift your arms up in this forward plane as far as you can. Any pain or discomfort doing that?
Not at all.
No. That's great, and you can see that Sam's got an equal range of motion here. The next thing is abduction, so I get you to bring your arms down. I'd like to get you to bring your arms up slowly in this plane, all the way up as far as you can. And once again, it looks like he's got no pain or discomfort, and he's got a full range of motion. A painful arc is where the supraspinatus tendon is impinging, and patients may describe a painful arc on doing that. The next movement is external rotation, so I get Sam to pop his arms in by his side and then to externally rotate his arms out as far as they'll go. And once again, we're looking for an equal range of motion. The next thing is to look for internal rotation. Internal rotation is a little bit difficult because the body is in the way. So by convention, what we ask the patient to do, if I can get you to turn backwards, Sam, is to bring your arms behind your back and try and lift your thumbs up as far as you can go. So this is actually a component of internal rotation and external rotation, and we're really looking to see how far Sam's thumbs go up. That's super, that's great. And once again, we're looking for an equal range of motion. Loss of movements at the shoulder may be the result of a mechanical block where there is a loss of both active and passive movements, such as in osteoarthritis or frozen shoulder, or a motor block where the patient is unable to actually move their shoulder whilst the examiner is able to do so passively, such as in rotator cuff disease. Now, for example, if Sam had a lag lifting his arms up, so if I get you to bring both your arms up as if the first movement, that's great. And this one goes all the way up, for example, so pop that one all the way up there, and this one hasn't. The question is, why is he not able to lift his arm up? Is this a mechanical cause? Has he got an arthritis in his shoulder? If he has an arthritis and I try and lift it up further, it just won't move because it's blocked. If he's torn a tendon, then I can easily lift his arm up and it will, because he's got no mechanical block. And then the next question, has he got enough residual strength to hold his arm up there? So when you do this, you have to ask the patient to hold their arm up. When you let go, you have to be prepared to catch it as the arm drops down. So if someone's got a massive rotator cuff tear, their arm would drop down and you'd need to catch it. What we're going to do is we're going to get Sam to bring his arms up in abduction a couple of times, and what we're really watching at is we're watching how his scapula moves. So Sam, if I can get you to bring your arms up slowly a couple of times, and you can see there's a measured amount of movement at the glenohumeral joint and a symmetrical amount of movement with his scapulae. So they're actually, and bring that back down again and move that up again gently, slowly. That's great. So Sam doesn't have any problems with his shoulder, just bring those down. So if he were to have a problem with his glenohumeral joint, what would actually happen is he'd move his scapula to its full excursion initially, which would in fact shrug his shoulder up. Then if he did actually have any movement with his glenohumeral joint, he'd then bring that out. So scapulohumeral rhythm, the most important thing is looking for asymmetry from side to side. There's no actual measurement of that, but it's just an indication that someone may have got some shoulder pathology.